بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا أكرم الأكرمين. Dear colleagues, this is one of the lectures in the series of the head and neck imaging. It will deal with imaging of the salivary glands. And in the salivary glands we have to know something about the anatomy, and we will mention the stone diseases, the sialadenitis, as well as the salivary neoplasms, including the epithelial tumors like adenoma, carcinoma, and Wharton tumor, as well as the non-epithelial tumors like hemangioma, lymphangioma, lymphoma, lipoma, and sarcoma. You know that there are a lot of imaging modalities for evaluation of the salivary glands, starting by the plain X-ray, which can show the radiopaque calculi, calcification in the region of the salivary glands, and if there is malignant disease associated with erosion of the adjacent part of the mandible, it may appear in the straight radiographs. Sialography is one of the techniques that was frequently used in the era before CT and MRI for detection of radiolucent calculi, the diagnosis of sialectasis, and to show some duct displacement or amputation in cases of space occupying lesions. Ultrasound is now one of the best imaging modalities for evaluation of many of the lesions in the head and neck, including the regions of the salivary glands. Ultrasound is a mobile unit that can reach the patient in the ward. It also does not use any ionizing radiation, and it's very simple and real time, so you can have the full study of the salivary glands in a very short time compared to the examination by CT and MRI, which may require some time patient preparation. And for sialography, we use the specific catheter or a sialography catheter, and this catheter is introduced into the orifice of the main parotid duct, which is located adjacent to the upper second molar tooth. And whenever you open the mouth of the patient and push his cheek, then you can easily identify the opening. Then you cannulate and inject a radiopaque contrast medium. Then you have films, and after injection of contrast, you can see the main parotid duct as well as the intraglandular branches. And you may have the lateral view, the oblique view, and the frontal view. In the frontal view, you can see the region of the parotid gland, and you see the main duct as well as the intraglandular branches. But usually the lateral or oblique views provide an optimal image for the main parotid duct, as you can see, for evaluation of filling defects or restrictions, and you can also show the intraglandular branches. For evaluation of the submandibular salivary gland, you open the mouth of the patient, and the patient is asked to elevate his tongue so that you can look at the mouth floor. On either side of the midline plane, you can see a very small opening here and there, and this is the opening of the main submandibular duct. Then you push the sialography catheter in the desired side, then you inject contrast media, and you can have this appearance. This is the main submandibular duct, and near its distal branch you can see a filling defect, which corresponds to a stone that was detected in the plain X-ray of the submandibular region, which is used to be called the occlusal open mouth view. And for evaluation of the salivary glands by CT, you may have the axial and the coronal planes. And the sections are usually obtained at 3 millimeter interval, and you select a suitable field of view to outline the whole anatomy and pathology if present. You may use the bone and soft tissue window settings, and to ensure, as in any part of the neck, the symmetric patient position, and sometimes you need to inject the contrast media intravenously. For evaluation of the salivary glands in the axial view, you start usually below the ramus of the body of the mandible, and you proceed upward and you may proceed parallel to the body of the mandible until you reach the skull base. In the coronal images, you start from behind the angle of the mandible, perpendicular in a perpendicular plane to the skull base. Then you go until you finish or you reach the paranasal sinuses. And this is the normal appearance of the parotid glands by CT and MRI. T1 weighted image, the CSF is black. T2 weighted image and CSF is bright. In the CT scan, you can see that the parotid gland is somewhat hypodense because the secretions in the parotid gland are watery secretions, in contrast to the secretions within the submandibular salivary glands, which are more viscid. Then in the T1 weighted image, you can appreciate the superficial and deep lobe of the parotid gland on the left side and also on the right side. In the T2 weighted image, there is some decrease in the signal intensity of the gland. And this is the normal appearance of the submandibular salivary glands by CT. The glands are more dense, of course, compared to the parotid glands. And in the T1 weighted image, the look of intermediate signal with some decreased signal in the T2 weighted images. And this is the submandibular salivary glands in an axial contrast enhanced CT image. You see this is the left one, and this is the right submandibular salivary gland. Then starting by the salivary calculi, you know that they are common in the submandibular gland and relatively less common in the parotid, and is relatively rare in the sublingual region. In about 25% of cases, the stones are multiple, and in about 20% of cases, the stones are radiolucent. Then usually the stones in the submandibular region are more sizable than the stones in the parotid region. And here you see two very big stones in the region along the course of the right submandibular salivary duct. And if you look here and you see that the submandibular salivary gland is enlarged and it is more dense compared to the left submandibular salivary gland. And one of the important issues is to look to the overlying fat planes. Then you can see some stranding or dirty appearance. This is an example of a big submandibular salivary stone seen in the occlusal film, and this the appearance of the stone at operation. Then you should know that the parotid duct is coursing subcutaneously outside the masseter muscle until it reaches its opening into the oral cavity. And this is the left parotid gland, and this is the right one. The parotid gland here is more enhancing, and you see that the fat planes subcutaneously are stranded. And if you look here and you see that the parotid duct is markedly dilated, the wall is enhancing, and near its terminal part you can see this calculus, which is located in the main parotid duct leading to sialectasis. Then another example, in here you can see a stone in the near the terminal part of the parotid duct, and the duct is dilated, the parotid gland is enlarged, it is enhancing, and very importantly, you look to the subcutaneous fat, which is stranded or dirty. Then salivary calculi. Now we came to the issue of salivary gland infection, and you know, one of the common infections is the viral, which is known as mumps, and sometimes you got bacterial infection by staph or streptococci. And one of the major issues for diagnosis of inflammation and the infection of the salivary glands is to look to the adjacent fat plane. And because of the congestion and the inflammatory reaction, you will frequently see that the subcutaneous fat is stranded whenever compared to the opposite side, which is normal. Then this is the right parotid gland, which is enlarged. It is heterogeneously enhanced, and very importantly, see that the fat plane in the subcutaneous region adjacent to the gland is congested or stranded or dirty. This is the normal left parotid gland, and this is the parotid gland which is inflamed. The gland is enlarged, it is enhancing, and you see that the fat planes are stranded. And this is also inflamed right parotid gland compared to the left one. The left is good in size and density. The fat planes overlying the gland is maintained. But here you see that the parotid gland is swollen, it is enhancing, and the subcutaneous fat is stranded. And this is inflammation of the right submandibular salivary gland, secondary to obstruction of its duct by this small stone located along the course of the submandibular duct. The left submandibular gland is good concerning its density and enhancement, with the surrounding fat planes are clear. But here the gland is enlarged, it is heterogeneously enhanced, the facial planes adjacent to the gland are thickened, and you see some stranding in the adjacent fat planes. Also, you can see a marginally enhancing lesion within the affected gland, which is characteristic of an abscess formation. And chronic inflammation may lead to sialectasis, and this may be due to recurrent infection or granulomatous disease, or sometimes the autoimmune disease. And this will result in recurrent swelling of the gland, and there is a characteristic appearance on sialography, which is known as leafless fruit-laden tree. Like this one, and you see the fruits and you don't see the leaves. And here is the main submandibular, the main parotid duct, and you can see that there is some pooling of contrast within the duct system, giving this characteristic appearance. We call it sialectasis. And whenever the pooling is minute, like this dots, we call it punctate sialectasis. While if it is large, we call it sialectasis with more contrast pool. I do not remember exactly its name, but we call it sialectasis. Then one of the known diseases in the parotid gland is the autoimmune disease, particularly the Sjögren syndrome or Sjögren disease, also affection of the gland by systemic lupus or rheumatoid disease. This is a chronic systemic autoimmune disease, and it usually affects women at this age group, where will result in recurrent tender swelling of the parotid glands bilaterally, and there is an intimate relation between Sjögren and non-Hodgkin lymphoma. And it is stated in the literature that Sjögren disease has 44 times a greater incidence of non-Hodgkin lymphoma in the parotid region. For the diagnosis of Sjogren disease, you should have bilateral enlargement of the parotid glands containing many cystic lesions, small cystic lesions. The cystic lesions will appear hypodense on the CT, as you can see here. They appear low signal in the T1 and the high signal in the T2 weighted images. Then, yes, this is the globular atelectasis whenever you got more contrast pools within the ducts of the gland. Then this is the Sjogren disease, and you can see asymmetrical enlargement of the parotid glands. The left is more large. Then here are multiple small cystic lesions present in both sides, and this is characteristic of Sjogren disease. Parotid abscess is also a known pathology in the clinical practice, and the abscess, like anywhere in the body, is a fluid containing lesion that is marginally enhanced, and the fat planes, because of inflammation, will be, as you can see here, they are dirty, they are stranded with thickening of the overlying skin and the facial planes. Then there is a big differential diagnosis for cystic lesions in the salivary glands, and I will mention this Wharton tumor later on in lymphoepithelial cysts, and first branchial cleft cyst will be mentioned also in the lecture of the suprahyoid neck, sialocele ranula abscess, necrotic intraparotid lymph nodes, necrotic tumor, and HIV-related cysts. And this is an example, coronal T2 weighted image of a patient who is HIV positive, and you can see multiple cyst-like structures filled with fluid in both parotid glands. And the differential diagnosis of these cysts is big, but you should concentrate on the three main pathologies, which are the lymphoepithelial cysts related to AIDS, Sjogren disease, and non-Hodgkin lymphoma. Then this is HIV-related lymphoepithelial cysts. This patient is known to be an HIV positive. The parotid glands are enlarged. They are containing numerous cyst-like structures together with punctate foci of calcification. And if you don't know the history, this is good for the diagnosis of Sjogren disease. Sialosis means that benign symmetrical enlargement of the parotid gland having the normal CT density with no evidence of inflammation. The subcutaneous fat is maintained, and this case is known as sialosis, which is chronic non-tender enlargement of the parotid glands. They are bilateral and symmetric, and there is no evidence of inflammation or neoplasia. In cases you did a sialogram, you will got a splaying of the duct system without erosion or displacement, and the CT will show bilateral enlargement of the glands maintaining their density. The importance of this disease is it is associated usually with some of systemic diseases like diabetes mellitus and some of the medications. So if you diagnose sialosis, you should look behind it. Then salivary neoplasms, we have mentioned that we have epithelial and non-epithelial tumors. The epithelial tumors are the adenoma and the carcinoma, of course, and most of the lesions will occur in the parotid gland, less common in the submandibular and less common in the minor salivary glands, and also relatively rare in the sublingual region. The malignancy is on the opposite side. It is more higher in incidence in the sublingual than the minor salivary, than the submandibular and the parotid, meaning that the incidence of benign tumors in the parotid is more than the incidence of malignant lesions. And this is just an example to show the difference between a benign lesion like this soft tissue nodule within the superficial lobe of the right parotid gland and the malignant lesion, which is an infiltrative pathology with destructive characters and invasion of the surrounding structures. Then the salivary, if you see a mass in the parotid gland and you want to judge the possibility of being benign or malignant, the first possibility, the first supportive criteria is the localized, well-defined margin of the lesion, which usually favors the diagnosis of benign lesion. Also, in T2 weighted images, if you see the lesion, if you can see the lesion hyper intense, then it contains more water, then it is more to the benign side. Then lobulated mass with heterogeneous signal, this lesion may be benign or malignant. An infiltrative mass with areas of necrosis is suggestive of a malignant lesion. Pleomorphic adenoma represents about 95% of salivary gland masses, and about 85% of these adenomas occur in the parotid gland. And sometimes, if it is not treated, then 25% will turn malignant. This lesion is usually solitary and well defined. It can be bilateral, as you can see in this example. There is a well-defined homogeneously enhancing lesion on the right side and another smaller well-defined homogeneously enhancing lesion on the left side. And this is the pleomorphic adenoma, well-defined homogeneously enhanced lesion in the superficial lobe of the left parotid gland. And you remember, if this lesion is not removed, it may turn malignant in about 25% of cases. Then this is the appearance of pleomorphic adenoma by MRI, T1 weighted image and T2 weighted image. The lesion is here well defined, of intermediate signal in the T1, high signal in the T2, meaning that there is a lot of fluid inside the lesion, meaning that it is on the benign side. And this is T1, and this is T2, and this is T1 post contrast. Then you see an intermediate signal lesion, which is bright in the T2 weighted image and shows faint homogeneous post contrast enhancement. This is also a pleomorphic adenoma, axial T1, axial T2, axial T1 post contrast. You see the lesion of intermediate signal and bright signal in the T2 with homogeneous post contrast enhancement. This is a pleomorphic adenoma in the deep lobe of the parotid gland. You know, this is the superficial lobe, and the deep lobe is intimately related to the parapharyngeal fat, as I have explained in the lecture of the parapharyngeal spaces. Then this is an adenoma in the deep lobe of the parotid gland. This is the adenoma. And pleomorphic adenoma can also occur in the submandibular gland, but is more common in the parotid gland. And this is an example of an adenoma in the right submandibular salivary gland. This is the left submandibular salivary gland, which is normal. Then we came to the Wharton tumor, which is the second most common benign parotid tumor. And this lesion is usually occurring in old age, relatively old age, from 40 to 70 years, is very more common in males than in females, and is intimately related to cigarette smoking and also radiation exposure. This lesion do not turn malignant, and it's written in the literature that malignant degeneration of Wharton tumor is extremely rare. This lesion is a painless swelling in the region of the parotid gland, and it may appear usually cystic or may have a cystic component. And this is a typical example of Wharton tumor. You see a solid part and a cystic part in the superficial lobe of the left parotid gland. Wharton tumor is commonly to see it multicenteric. I mean multiple lesions in the same parotid gland or multiple lesions bilaterally, and the incidence of multicentricity or unilateral or bilateral is about 20%. Then this is the sharply defined lesion, which usually have a cystic component and a solid component. Then This is a male patient, 63 years old, and you can see a mass in the superficial lobe of the parotid gland with cystic lesions inside. Then you think of Wharton tumor. Then if you see multiple lesions in the parotid gland, in one of the parotid glands, like here, this is the parotid gland, and you see 1, 2, 3 lesions. On the opposite side, and you see also a solid lesion. Then I used to diagnose this as enlarged intraparotid lymph nodes, but I was wrong, because the more likely diagnosis here, even in absence of a cystic component, is to diagnose bilateral multicenteric Wharton tumor. Then the parotid may have a simple cyst, and like any cyst anywhere in the body, it should have the 7 criteria, the 3 positive and the 4 negative criteria: paper thin wall, sharp well-defined margin, clear water content, no evidence of septation, no evidence of enhancement, no evidence of mural nodules, and no evidence of calcification. Then the malignant epithelial tumors are in the course of carcinomas, like the mucoepidermoid and adenoid cystic carcinomas. The mucoepidermoid carcinoma represent about 30% of the salivary gland malignancies, and is more common in the parotid, less common in the other salivary glands. Then this is a malignant lesion of an infiltrative destructive character, and may be associated with enlargement of the cervical lymph nodes. Then you see here a lesion infiltrating the superficial and the deep lobe of the parotid gland on the right side, showing heterogeneous post-contrast enhancement. Then in the neck, you see this is the submandibular salivary gland, and this is the right one, and this very big lesion represents an enlarged metastatic lymph node. This is also a deep lobe parotid tumor, and you can appreciate that it involves the deep lobe, displacing the parapharyngeal fat medially, and because of the heterogeneous enhancement, you may assume the possibility of a malignant lesion. Non-epithelial tumors represent about 5% of the salivary glands tumor, and they usually seen in the children, most likely, like hemangioma, lymphangioma, lymphoma, lipoma, and sarcoma. And hemangioma is one of the known tumors affecting mainly the parotid gland, and is seen usually in the children. And 90% are of the capillary type, meaning that it is an infiltrative type. Cavernous type occur in adults or older children. The lesion is rapidly enlarging, and they may be associated with bluish discoloration of the overlying skin. But you know that hemangioma is a vascular lesion, and this lesion is strongly enhanced after injection of contrast medium. Like this one, a big lesion affecting the right parotid gland, the deep lobe, and the superficial lobe. And one of the known issues about hemangioma anywhere in the body is that, especially in the head and the neck, it may regress by aging. If this will appear in a child, it is not a congenital lesion. It will appear after some time from the birth date, then it will enlarge, then start to regress in the adulthood. This is bilateral parotid hemangioma by MRI T1 weighted image and T2 weighted image. You know that hemangioma will show very bright signal in the T2 weighted images. And this is bilateral parotid gland hemangiomas by contrast enhanced CT. You can feel the strong enhancement of the lesions. Lymphangioma or cystic hygroma is one of the lesions that occur in the neck. It is very extensive, that it can infiltrate all the facial planes here, and also may involve the region of the parotid gland. And this lesion is characteristically a cystic lesion filled with fluid. It may contain internal septations. It may show some faint marginal enhancement, but it does not contain mural nodules or any signs of malignancy. Inside the parotid gland, there are lymph nodes, and these lymph nodes are not usually seen if they are normal. But whenever the lymph nodes are enlarged, they will form multiple masses. And as I have mentioned, if you are confronted by multiple solid masses in the parotid gland or in both parotid glands, it's better to diagnose this as bilateral multicentric Wharton tumor rather than to consider it lymph nodes, unless you have other lymph node groups that are enlarged in the neck, as I will mention after that. Then what are the possibilities? You know, hyperplasia, you know, inflammatory disease, and lymphoma and metastasis. These are the most common lymph node pathologies seen in the clinical practice. Lymphoma is rare in the salivary glands, but secondary lymphoma occur in about 1 to 8% of the cases with lymphoma, and 80% of these will affect the parotid region. You know the intimate relation between Sjögren and the non-Hodgkin lymphoma, and also the intimate relation between HIV and lymphoma. Then you got an infiltrative lesion, which is affecting the parotid gland and invades the surrounding structures. This is the criteria of malignancy. But when to diagnose lymphoma? If you see bulky, homogeneously enhanced lymph nodes, which are typical of lymphoma. And here you see the bulky appearance of the lymph nodes that are homogeneously enhanced, then you know that you most likely you are dealing with a case of lymphoma. And this is also a case of Hodgkin disease. And you see the left parotid gland is involved by a mass, and ipsilateral deep to the sternomastoid muscle, and you get multiple enlarged lymph nodes that show homogeneous pattern of contrast enhancement. And this is lymphoma of the parotid and the submandibular salivary gland, as well as the lymph nodes. This is the parotid lesion, and this is the submandibular lesion. This is the normal right submandibular salivary gland, and this is lymph node, and this one is also lymph node enlarged, and there are here multiple. Then you got submental and submandibular and upper deep cervical lymph nodes. All the nodes are bulky and homogeneously enhanced. Then you think of lymphoma. Then lipoma can also occur within the parotid gland, and you got the fat containing lesion within the superficial or even in the deep lobe of the parotid gland, with no evidence of enhancement, calcification, or soft tissue components. And this is an example of parotid lipoma. In the T1 weighted image, you see the fat signal of the lesion, which is occupying the superficial lobe and extending deep into the deep lobe of the parotid gland adjacent to the parapharyngeal fat. And in the T2 weighted image, you expect some loss of signal of lipoma, but this is the appearance which is classic for fat containing lesion. Alhamdulillah Rabbil Alameen, wa salatu wa salamu ala ashraf al-mursalin. Thank you very much.